The tongue is actually a really, really powerful muscle. And when it's resting on the top of the palate, it's helping the jaw to expand.
Yes.
So when it's on the bottom, it's not doing that job.
Hi, I'm Dr. Bernard Siew, and
I'm Tiffany, Dr. Tiffany.
And welcome to The Bite Angle, is it?
Yes, The Bite Angle.
Yes, I
our
love that
fresh
name.
new podcast.
Yes, yeah. So today we wanted to speak a little bit more about, it's a big topic, but it's about airways, how we breathe, and how that actually relates to dentistry. So I think we can start off with probably a couple of even personal experiences. So Tiffany, you do a lot of orthodontics, and can you share a little bit about how that can be very much related to our airways?
Yeah, for sure. With orthodontics, we are moving the jaws and we are moving the teeth. So there is some changes in this part of the face that is related to breathing. And a lot of people, when you think about breathing, you think about breathing from your nose, and then there's a pipe that goes down to your lungs, and that's how you breathe. But there's also the large segment of people who breathe from their mouths, and it could be because of a nasal obstruction, it could be because of a habit, but that's how they get their air, and they breathe from their mouths, and it can cause a lot of dental changes as well. So when I do orthodontics, it's always something I look out for, whether they're mouth breathing or whether they're breathing through their nose. And mouth breathing, it may seem like an innocent habit, right? Like maybe they just prefer it that way, but it can have a lot of impacts on the rest of the body. And for example, they could have like the tonsils at the back and the adenoids at the back, they could be more enlarged. And then it could also translate to problems at night when you're sleeping. So it's a very important topic for sure. Yeah. And how do you see any of that in your daily practice as well?
Yeah, I do actually, and oftentimes I see more adults than kids, and in adults they actually already manifest in quite a few different ways, and I think we tend to forget that our jaw, especially our upper jaw, is the width of that upper jaw is basically the base of our nasal passage.
Yes.
Right. So
yes.
We've also found over time a narrowing of the jaw. So not only do we see a lot more malocclusion where there's a lot of crowding with the
As
teeth.
everything gets narrower.
Very rare do we see gaps in people's teeth
Yes.
anymore,
Yes.
right?
It's not common.
Yes. And you see like this narrowing of the jaw. And also then, because of that, a narrowing of the airways. And sometimes, actually, we're as dentists, we are positioned in the right way where we often would see our patients quite regularly. And if we take a panoramic X-ray, we will actually be able to see the nasal passage.
Yep.
And sometimes we can surprisingly see a lot of soft tissue that covers their airways. And it's, like you said, it's very much a chicken and egg situation, because sometimes if you don't breathe very, very well, then you get a malocclusion problem. And sometimes if you have a malocclusion problem, then you end up having breathing problems. So which one comes first, we're not quite sure. But yeah, it can start at a very young age as well.
Yeah.
And so nowadays, from what I see with a lot of the adults, and later on it will manifest as snoring, or they have sleep apnea problems. And then they have a cascade of different issues. Now they find that it's related to high blood pressure, narcolepsy, where they get very sleepy in the middle of the day and sometimes get into accidents as well. And higher levels of diabetes as well. And so, it all becomes quite...
It affects the entire body, the health of the entire body.
That, don't we?
And
breathing is such a basic thing.
Yes.
And it seems like, especially in modern urban life, I think it's also, I spoke to an ENT, and he actually says that it's more common now than before, where more people have asthma problems, but also a lot of very low levels of inflammation,
Inflammation,
and
right?
a lot
Yeah.
of mucus production.
Yes.
Like just because of production.
Sinusitis, right? A lot of people call it
That's
sinusitis.
right,
Like my
yes.
sinus are acting up.
Yes,
that kind of
every
thing.
morning, right?
Yeah,
we
yeah,
speak to so many of our patients, and they actually say that.
Mm-hmm.
So it's one of the things that I try to tell the parents of my younger patients that's what we look out for. We look at the jaw to see how teeth are developing. And I guess, would you say that there are so many more easier and early intervention ways to do the orthodontics now?
Yeah, I think so. Because with the jaw, when we look at how the jaws grow in young kids, the upper jaw grows first. And then the lower jaw adapts basically to that space or the width of the upper jaw. So what we need to target is the upper jaw. If we notice in young kids that we see if it's narrow or one sign could be that with the baby teeth there's no gaps between them. So they're very closely aligned together. And then sometimes parents may think, she's got perfect teeth. But what we need to know is that the baby teeth are often much smaller than the adult teeth. And if you don't have space in your jaw anymore, then as the adult teeth come out when you're about 6, then you'll have problems with crowding because they don't have the space to come out into. And so we have to watch out for these sort of early signs. And I believe that early intervention is really important because that's at the age where the kid, we can sort of encourage the growth, we can move things around. And if we get enough space, then the teeth will have the space to come out naturally and will have much less malocclusion, which, like we were saying just now, it can lead to less breathing problems. So the age that we are looking at for early intervention could be anywhere from 6, actually even 4. I've seen some 4-year-olds, 5-year-olds, to maybe about 10, 11, 12, maybe at the oldest, because the growth in that period of time is the most, and then it starts to taper off after 12, 13.
Yeah.
But before 4, even before 4, I think that, you mentioned an ENT. I'd like to share a story about my son. He's 4 now, but when he was 2, we noticed that he was breathing, he was snoring when he was sleeping. And it's, at first you think, it's just he's really tired, and it sounds a little cute, right, when a little boy is snoring. And then, but being dentists, we are aware that snoring is not a good thing, and he was grinding as well a little bit. So we kept an eye on it, and it didn't improve by itself. It just got a bit worse. And we saw a pediatric ENT. She did a scope, and it's quite horrifying. It was like 90% blocked on on the nasal turbinates, and the adenoids were also very swollen, and also the tonsils as well. Everything was inflamed. So he was getting this sort of chronic inflammation. Every time he fell sick, it would get worse. It would become like a full-on obstruction, and that's where he would start to snore really badly. And at first the treatment suggested was like steroids and nasal sprays, and if it didn't improve, surgery. And we were like, he's 3. He's so young for surgery. And we were struggling a bit, like, it's sleeping, maybe it's not hurting him, right? The breathing, it's not hurting him. Should we just let him grow out of it? Which most of, actually our parents said, don't put him through surgery. It's a GA, so he goes under general anesthesia. He would have to spend a couple of days in the hospital. It's a lot to put a young kid through. But because of our training, I think, in this area, and also when talking with the pediatric ENT, we decided to go ahead, get his airways cleared, because although breathing is not something that, it's painful or it would sort of kill you, but it does actually, right? It does actually affect your general health, like you mentioned. And breathing badly in kids can affect the jaws too, and so it doesn't develop properly, and then it goes into again crowding and
it's a cascading effect.
It's a cascading effect, yeah. So we decided to do that for him, and the change is immense. He's sleeping better. he doesn't wake up in the middle of the night, with terrors and nightmares and things like that too much. I mean, there is still some because he's a kid, but much better, definitely.
His mood is much better?
His moods, yeah. The emotional sort of imbalances are much better because he used to have meltdowns quite often. And looking back, it was because he was tired. He was just tired the whole day. And it was often when closer to the end of the day where, he's running out of battery and he would really melt down. And after we resolved that sleep apnea, it did get a lot better. So then he became, I would say even in school the teachers notice it, that he's been more sort of responsive, he listens better. So all these sort of things, I think it has a psychosocial impact as well, because if you're not sleeping well and you're tired, I put myself in these shoes. You're tired and you're being told off the whole day because you're doing something, you're a kid. And then it would impact you in nothing I do is correct, Everyone's always telling me off. And then I feel like that also is something we should consider.
Yes.
Like the mental health of the kids when there's this sort of things happening.
Yes, for sure.
Yeah.
Actually, we in our family have this same experience. So my son, who's now 7, but when he was 4, he actually had his turbinates reduced and his
turbinates in the nose.
Removed. Yeah. And so it was the same thing. It was getting sinusitis consistently, but never recovering.
They would just fall sick all the time. They would be sick all the time.
And it just takes so long for everything to drain. So we were given the same advice as well. You can be conservative, but he'll be on longer term medication.
Yes.
Either that or the surgery. And actually I found out for myself that I have had the same issue.
Oh, okay. When you were young?
No, till this day.
Oh, okay.
Yes. And also my wife had the issue as well. So she and my son both had the turbinate reductions.
Oh, right.
And and I mean my son, we could see the difference now. If he catches a cold, he recovers in 2 days.
Yes.
As compared to 3 weeks before.
Yes, that's what I noticed as well.
And his jaws have actually fixed themselves.
Oh.
So that's actually something to think about as well, because when you have the mouth breathing issues, then the jaw structure will actually adapt to what you need to do to mouth breathe, right?
Yes.
And so that's what we talk about. The tongue position changes.
Tongue position,
Yeah, and so basically they go down a different natural path, and that's really the issue. So I think now it's to deal with the problems, and I think it was a very good point that you brought up earlier about the growth of our jaws. So there are certain milestones that our jaw bones have. If I'm not wrong, I think there is if we want to play it safe, 10.5 would be the latter stages of trying to expand the upper jaw, isn't it?
Yes.
Because
but, yes, because I think 10.5 is for both boys and girls. It's still the later part of the upper jaw growth.
Yeah, that's right. Yes, yeah.
But I mentioned to a later age, like 12 and 13, because for some, for boys especially, it's a bit later. It can be a bit more delayed. For girls, sometimes their sort of skeletal maturity occurs earlier. So it can be a bit late at that stage. But I always think it's good to come in if you suspect that they're having a narrow jaw. Because then it's still... There probably is still something we can do about it.
That's right, yeah.
Rather than to wait until they're an adult.
For sure.
And for sure, at that point, all the growth is gone.
Yes.
And at that point, we might be looking at extractions. I try not to do a lot of extractions nowadays with orthodontics, because they've been finding out that people with orthodontics that had extractions in the past, they're more likely to have sleep apnea because their jaw volume, the overall volume that is inside the mouth, decreases, and so the tongue has no space basically, and it falls backwards.
Yes.
And that's linked to sleep apnea, right?
Yes.
So I try not to do a lot of extraction orthodontics nowadays, and if we can expand and get that space early on, then we can have a better chance of not doing extractions. But I want to go back to the point earlier where you mentioned like the tongue position, because that's actually like my pet topic in a sense.
Oh, right.
Yeah.
Okay. Tell us more.
I like to see. So earlier, I think in another podcast, we talked about having a photo studio, and during when I'm talking to the patient as well, I'm looking at how the tongue is, and sometimes, and it's a habit usually, but sometimes you can see the tongue sort of pushing at the teeth, or sort of pushing close to the teeth, and it sort of pokes out a little bit, and that's called a tongue thrust. Some people have this habit, and they're not aware of it.
Right.
And in mouth breathers, the tongue tends to be low and down, sort of on the bottom of the mouth, where it really should be on the top of the palate. Yeah. And when it's on the bottom, it's just staying there, and that's how they open their mouths, and the air can go in on top of it, right? That's how they mouth breathe. But having the tongue on the palate is really important for the growth, like you mentioned, for the growth to happen, because the tongue is a natural expander. The tongue is actually a really, really powerful muscle, and when it's resting on the top of the palate, it's helping the jaw to expand.
Yes.
So when it's on the bottom, it's not doing that job. So the jaws, they don't get that expansion to happen. And what I often also sort of retrain the patients, I would say I would suggest, if I notice the tongue habit being low down or thrusting, then I would try to get them to, change their habit of where the tongue should be sitting often, by doing a very simple exercise.
Okay, what's the exercise?
Yeah, so I get them to swallow their saliva or sip of water. And when you do that, and I'm doing it now, naturally your tongue goes up, and it rests in that's the natural position it should be in.
Yes.
Because I notice if I tell them, put your tongue on the palate, everyone does this.
Yes.
You're just poking up at it.
But it needs to be the whole tongue that presses against the
and it's a very slight pressure. You're not pushing out actively. Yeah. It's a resting position, so it's like you don't have to actively push your tongue. And I often ask my patients to try and catch themselves throughout the day. Notice where your tongue is and try to reset it. And it's like posture. It's like like our body posture and things like that. If after a while it does tend to improve. And I've seen also like some kids where the parents didn't really want to do early intervention that early. So I go through this exercise. I ask them to try and practice, and also lip closure.
Lip seals, right?
Lip seals, yeah. Some kids, they tend to leave their mouths open when they're watching TV or they're focusing on something. They sort of leave their lips open, and the lip is another very powerful muscle that keeps the teeth backwards. Yeah. So these sort of simple things, yeah.
So if you see, people with protruding teeth and with the lips being very, very loose and open, you already can tell that they're a mouth breather, right?
It tends to go hand in hand.
Yes. I think similar to thumb suckers too, right?
Oh, yes.
Because the tongue thrusting is almost like a mechanism to seal the mouth whenever they are trying to swallow.
Right. Yeah, right.
Yeah. So I was speaking to a patient of mine who's also a speech therapist.
Oh.
And so I was asking her about what do they do when it comes to the training of the tongue, because I was mentioning to her that I notice quite a number of mouth breathers, not all, tend to have lispy speech, right? So if they have to speak in a specific way, where their tongue needs to be almost stronger in some ways, would that actually help in cases where we want them to practice the tongue being pushed up to the palate? And she said, it's sometimes a vital exercise that they also try to do. So they can be very multidisciplinary observations like this. You have a speech therapist, an ENT specialist who's very much in tune to what's happening with the breathing as well, and a dentist as well that can also observe the regular changes that's happening in the mouth. So with what I did with both my kids, actually, my older one, who's now 14, but she had a very narrow jaw. So it was exactly what you said before. She had what they typically call the childhood Hollywood smile. It's very straight.
It's very straight. Everyone would say, "Oh, perfect."
Yes,
she's
exactly.
so beautiful. She's got great teeth.
Yeah, we as dentists know, oh no, that's going to be a real crowding problem.
Yes.
And so I actually got her on Invisalign very early on. And I think it was a very good point that you brought up, is that you can go very early to intervene, but also it depends on the personality and the characteristic of each child.
Yes.
Because it's impossible to do it
you can't force them.
Yes, you can't force them.
Yeah.
And they have to wear it to school as well, right?
Yes.
These devices. And,
they have to be on board with the whole process.
And the parents have to be on board as well.
Yes.
And so the other thing that we discuss with the patients and and if they are very young patients, then the parents as well, it's about how long this process is going to take. Because if they start at the age of, let's say, 5, we need to make sure that they are, even if the treatment is done to completion, they will probably need a lot of retention work.
Yes.
That will go
keep the stuff
up
that
to into their mid-teens at least, to be very, very good at it. And there can sometimes be what I nickname as treatment exhaustion. Everybody just gets exhausted after a while, right? The parents going, "Oh, you've lost another of your appliances. We need to get you another one." It becomes a very expensive exercise. So unless everybody's very committed to doing it, sometimes it's just making sure that we observe and monitor at least. But usually by a certain time, everybody's going, okay, let's start. It's time to do something about it. But it's first to be aware of that these problems
it's good to
happen.
be aware.
Yes. Now, for adults, it's a different manifestation. So what we often find is the grinding, like you mentioned before, is that they are either grinders or the other symptom that we see a lot is that they snore.
Yes.
And actually, one psychologist patient of mine mentioned this in the chair. She said that they call it it's almost like a partial divorce. Where
because the snoring is so loud.
They call it a sleep divorce.
Right.
So it's husband and wife. They're still happily married, but they sleep in different bedrooms. And it's purely for sanity and the survival of the marriage.
I think if you have heard the apneic snore, it's called where the patient. Where the snore is so loud, it's beyond what you would imagine as a regular snore.
Yes.
Yeah.
It's like a motor engine.
It's worse. It's a motor engine next to you in bed, and it's like a V8.
Oh yeah.
It's
yeah.
And then I think so it's I can understand the divorce thing.
Yes.
My dad used to have sleep apnea. So
okay.
He was
so how did
snoring like that. So that's why we all when we went on holidays and sometimes we would share a room, right? When we were very young, we would always complain and say, "Dad, why is your snoring so bad?"
Yes.
It's and he didn't understand, because I think that was a good 20 or 30 years ago. It wasn't as well understood as it is now. We all didn't understand. It was actually a symptom of something worse.
Yes.
And earlier you mentioned narcolepsy.
Yes.
That happened to him. So he would be driving.
Yeah.
And then he would blank out.
Yeah.
And it's like microseconds. So he would be driving through, and then he would suddenly be aware that he's crossed that crossing.
It's scary, right?
And it's scary because you can't control yourself when that happens.
Yes.
So then once it happened, then he was really alarmed. He was like, he has to get it checked out.
Yeah.
And he got a CPAP machine. Which
Okay. Is the CPAP machine something that is of a concern to? As in to him, because some people say it's very disruptive.
Yes. So they
to-
said for the first year, that's when you either get used to it or you just give up completely.
Right.
Sleep apnea patients.
Yes.
So he was having sleep apnea. He was snoring. He was falling asleep. All the classic signs. And they did a sleep test to find out. And he was a severe
Right.
one. He would get so apneic that his brain wasn't getting oxygen to the brain, and it does reduce your life expectancy as well. And hypertension, he had that. He was overweight as well, so that didn't help with the snoring. So he did the sleep apnea, the CPAP, and it actually, he liked it because then he felt more refreshed. So he liked it. But definitely it was a struggle because you have this tube running through, and I tried it myself actually.
Yeah, right. Okay.
Because I was I think I'm slightly apneic.
Right. I think we all are.
Yeah.
Yes.
So I did try one of his travel ones, and it's not easy to get used to because if I'm a side sleeper, so I toss and turn a little bit.
And you wake up, right?
And you wake
Just
up because
as
you
soon as
feel this restraint. Yeah. But I think if you are apneic, if you have sleep apnea, it's worth that sort of that hassle.
Yes.
And for me, I'm not severe, so I did one of those take home. You put it at home and you check whether you have sleep apnea or not. So I was borderline.
Borderline. Like nothing to moderate, or
like nothing to moderate. Yeah. Borderline, you could probably get away without anything. But I think when I fell sick, then everything inside would swell and then I would become apneic.
Yes, exactly.
Yes. So I did one of those devices that you can put the mandibular.
Oh, like this.
Yeah, I think you do a lot of that, right?
I do. Yes. Yes. And I've tested one on myself as well. So I've become a little bit of a snorer recently.
Oh.
So
maybe that's as you were mentioning, the aging, it narrows your jaws and then it pushes everything.
And basically what I'm told is that the muscle tone around the floor of your jaw, the myohyoid muscle, tends to actually loosen. So when you're in what they call a tired sleep, right? So everything just goes slack and then it flops backwards, and it just throttles the airway when you're actually trying to breathe through. So that's how we should think about it too. So not all snorers are apneic, but actually there's just a higher chance. It just tells you that there is that ability for you to have the obstruction in the airway. And sometimes the airway being obstructed up here is, and if you fix that, there's another obstruction that goes to your lungs, because if you are quite heavy set and you've gained a lot of weight, all this tissue here will block the airways.
When you lie down and you relax.
Yes, unless you've got a really big jaw. And also, actually, just looking in the mouth, we can now tell whether someone has a lot of soft tissue. So if I get my patient to lie down in a chair, and when I check the tongue and the cheek area, I usually would get them to go ah. And if they go ah and I can't see the opening of the throat at all, that means they have a really long, meaty, soft palate and a very large tongue. Then the risk is very, very high. Of course. So sometimes this device is called a mandibular advancement device. For the uninundated out there, basically it's a two-piece device, one for the top teeth and one for the bottom. And basically all it does is that they all work in a very similar principle, where it keeps the lower jaw a little bit more forward. So when you're lying down like this, if not, the lower jaw, which is this one, will be set further back and it will just collapse in. So it is just to push it forward and to hold it more forward, so that the even if the tongue collapses backwards, there's still an avenue for the air to go through the nose. But there's a couple of things that needs to be done as well, which is that any type of mouth breathing habits or the tongue positioning habits also need to be addressed because there's so many things that we have to look out for.
Yeah.
If you just, let's say, do this device, but there's so much upper airway obstruction, then air can't go through there anyway. So what the CPAP really does is that it's active air, isn't it? Yeah, positive air
pressure.
So it will just push air through whatever.
Yes, if there's a small hole, I mean, they'll just pump it through.
Exactly. It's almost like a CPR for your whole night.
Yes.
And so for some patients, they say that it's kind of uncomfortable. It's a very weird feeling.
Yes.
That you are not really like breathing in, but air is just being shoved down your lungs.
Yes. I think depending on if you are severe or if the airway is quite narrow or constricted, then I think you do feel that pressure a lot.
Exactly.
And also the other thing is because it's constant wind, air being pushed down.
Yes.
Then a lot of people get like dryness in their throats, dryness in their mouths.
Yes.
When they wake up.
So
which is not very pleasant.
Yes. Yeah. So basically, to put everything in a nutshell, is that breathing and airway is very important, and I think it's something that in more modern dentistry we are aware of these issues.
Yeah.
And that's what we check for every time when a patient comes in, so that we just not look at your mouth and think of the teeth, but it's just the overall health and how that's actually affecting everything else. Everything's interconnected.
Yes.
And it's very, very important that we actually try to monitor and discover these things at a very young age. So don't be surprised if you see your dentist or a doctor about issues and they're looking down the throat and mention that there are certain issues that can be addressed. And it's very important to address it because we firsthand have seen it in our children as well. What a big difference it actually makes.
I think I always want to, it's more of like an awareness thing because then if you know about it, then you can do something about it.
Exactly.
And it may not be anything like a medical or dental treatment, but at least you're aware of it. And there's very simple things that people can do as well. Like if you're aware of nasal congestion, then maybe a saline flush is often suggested by the ENTs.
Exactly.
And then that could help in many cases.
And sometimes, and the ENTs say this too, is that because you may have grown up with this your whole life, you're don't even know what your normal is, right? This is has been your normal all this time. And this is what I hear from a lot of patients that have gone through upper airway removal of the obstructions, is that it's night and day difference. It's that they've never breathed so well. And was this what it is like for everybody else? It's not like a constant struggle. So definitely, if you're going to go to your dentist or your doctor, definitely have this looked at, and at least you're aware of what's going on.
Yes, it's very important, I think. All right, I think that's
so.
A good one.
That's it, and we'll see you another time, and we'll speak more about other facets of your oral health. Take care.
Thank you. Bye.